me record it. All right, y'all. So thank you very much for this opportunity. Thanks for joining us tonight. It's our honor to introduce somebody who's part of many of our kind of professional families, but also a good friend and somebody who's really pushing the envelope in a variety of ways. But one of the ways she's going to teach us tonight. So Dr. Wu is at the Mayo Clinic in Rochester, and she's going to talk to us about sort of her approach to one of the more challenging areas in upper extremity surgery and how we can, as we sort of kind of move into the frontier of this area, what do we see as the future of the tetraplegia? So okay, thank you very much for joining us. The floor is yours, but if you don't mind saving a little bit of time at the end, so that way we can have a sort of discussion and questions.
Yeah, sounds good. Well, thank you so much for the introduction and for the opportunity to be a part of the grand rounds, especially in the evening. Thank you guys for taking time out of your evenings to be here as well. I will try to keep my eye on the time to make sure that we have some time left over at the end for questions and discussion. I was thinking for the first half, I could go over a general overview of reconstruction in tetraplegia and then kind of work through a case together, and then we can sort of open the floor up. So we know that upper extremity function is very important in these patients. This is an older survey, but when asked patients who are tetraplegic, what gain of function would dramatically improve your quality of life, 50% of patients said upper extremity function. This is above walking, above sexual function, above trunk stability, above bowel and bladder. And these same patients, when you asked them at 3 years, it was the same. Even though these patients are incredibly resilient, they find ways to adapt to their loss of function. This is still as important to them. So even if they haven't had reconstruction, it's still something that would really benefit them, even if you're seeing them late or chronically. In a similar study, this is UK and Dutch data, which includes both paraplegic and tetraplegic patients. Similar end message, 80% of patients felt that improvements in hand function would markedly improve their quality of life. So this is really important. And if you can help patients in this way, you're really giving them increased sense of independence. This is a European study from Jana Dengler in Toronto. So this is looking at spinal cord injury level. This is a little bit of a busy slide, but if you look down the side, this is a C5 level injury patient at 6 months and 12 months, C6 at 6 months and 12 months, and so on. If you compare the C5 and the C6 patient at 1 year, and this is their independence in feeding, at the C5 level, 34% of patients require full assist. So they're not able to eat or drink on their own. And at a C6 level, only 4% of patients do. So said another way, if you can give these patients one additional level of function, you're helping them tremendously. From that same paper, looking at catheterization, comparing a C6 and a C7 level, the green lighter bars are patients who are independent in their catheterization, and the darker bars are patients who are not dependent. So either they have a suprapubic that their primary care needs to help them with, or a loved one needs to help them change. At a C6 level, 14% of patients are independent. At a C7 level, 32% of patients are independent. You can imagine the privacy, the ability to do this on your own, and how important that might be to someone's overall sense of self. So what can upper extremity reconstruction give patients? The first is elbow extension. If you can extend your elbow, you can reach out and interact with your world. This also gives you the ability to self-transfer and not just have to use a Hoyer lift, or to pressure offload. You can offload by pushing up on your elbows, locking them, and helping to prevent pressure sores, which is sort of the cyclical process in a lot of these patients. What may be counterintuitive, even in the patients who don't have anti-gravity triceps, even something as simple as when you're sleeping in bed and feeling hot and needing to take the sheets off of you, that requires triceps and extension. So even the M2 patient who's able to do that, those little things really make a difference. They are not having to call someone to help come and help them. And of course, hand and grip pinch function, they're using less adaptive equipment. They have more independence in feeding and self-catheterization and writing, and a lot of patients can get back to work and employment. So all of this, I know it's, I guess, obvious to say to people who work in hand surgery, but this is really important to patients. These little things really make a big difference. Out of the 300,000 patients with spinal cord injuries in the US, 60% are at a cervical level, but less than 10% of patients actually undergo extremity reconstruction. So this was a paper by Wagner et al., not the Dr. Wagner, but a Dr. Wagner. They were looking at what were the patient-specific barriers to this. So when patients were first told about surgery by a surgeon, they had a negative impression 67% of the time. When patients were told about the potential benefits of the surgery, they only believed this 60% of the time when they were told by a surgeon, compared to 100% of the time when they were told by a non-physician. They believed the gains of surgery were worth the risk only 20% of the time when told by a surgeon. And overall, learning about surgery from a surgeon made a patient 16 times less likely to actually want to have surgery. I think maybe this means that surgeons are poor communicators. Maybe we're rushing our clinic, but I think it also speaks to the vulnerability of these patients. From the time of their injury, they're admitted to hospital, they're seeing orthopedic spine, urology, neurology, PMR. Their the entire day is encompassed with dealing with this injury and adjusting to it. And they really trust the people that they see on a day-to-day basis, which is not you, the surgeon. So here for our new spinal cord injury patients, our PMR doctors reach out to me and say, do you think this patient would be a candidate based on chart review? And if they are, the PMR docs are the ones that are talking to the patients first, saying, would you like to speak to a surgeon? When I speak to the patients first, I say, this is just to give you information of what we potentially could do. We'll meet over the next few months as you continue on your journey and decide if this is something that's right for you. Okay, so thinking about spinal cord injury as a hand surgeon. We all know from peripheral nerve injuries and brachial plexus injuries, which are lower motor neuron injuries, that if we don't get a nerve signal, we don't reinnervate that muscle by 12 to 18 months, that muscle undergoes irreversible changes that no matter what you do, you can't get that muscle to work anymore. For spinal cord injury, this is at the upper motor neuron level. So a very simplified diagram, you have the upper motor neuron with the cell body in the brain that goes down into the spinal cord and synapses into the anterior horn. The lower motor neuron cell bodies in the anterior horn, and that goes to the muscle. Because your injury is in the upper motor neuron, this cell body and its connection to the muscle is still viable. It's still keeping that muscle alive, so to speak. This has really opened up the door for nerve transfers and late nerve transfers. You're no longer under that time crunch because you have your lower motor neurons still keeping that muscle alive and waiting for reinnervation. If you think about it this way, above the level of the injury of your spinal cord, those muscles, there's normal function. That makes sense. Far below the level of injury, there's paralysis of those muscles because of the upper motor neuron injury. The lower motor neuron, the cell body is still attached, but it's not connected to your brain. Those muscles, though, don't undergo that irreversible change. They're still waiting. It's that middle level that is a little bit hard to sort out. Right at the zone of injury, there's always a mix of upper and lower motor neuron injury. Although we say the spinal cord level is C5, C6, or C6 or C7, the actual zone of injury in the spinal cord can be 6 to 10 centimeters, so encompassing many different levels. And even on EMG nerve conduction, this is still a little bit of a gray area that we're not great at determining preoperatively. So in this zone, because there may be a lower motor neuron component, these muscles still may undergo those irreversible changes, and we may not have as much time as we think we do. I think that's one of the next things that we need to figure out in spinal cord injury is how do we tell what is upper and what is pure lower motor neuron injury? So your preoperative requirements to surgery, patients have to be at their own neurological plateau. So you're not expecting any intrinsic natural recovery of function. For most patients from larger European studies, if at 6 months after injury, patients have M0 in a certain muscle, we don't expect that muscle to recover M3 or functional use on their own. If they're an M1, M2 at 6 months, maybe they'll get that better with a little bit more time. But if it's truly an M0, then we don't think that that muscle is going to recover. So you may want to think about reconstruction. What makes this a little bit hazy is patients with incomplete injuries, anterior cord, central cord, they don't quite follow this pattern. So those patients, I'm often waiting a little bit more and giving them a little bit more time to make sure that I'm not taking away or reconstructing something that they don't necessarily. You have to have emotional stability and accepting their injury. Some of the newer literature for nerve transfer say we should intervene at 6 months. That's often still very, very early for a lot of patients dealing with a really big life change. Patients early on, they don't quite know yet how to manage pressure wounds, to check for infections. manage your catheter. So oftentimes they're dealing with a lot of this early on. You want to make sure that all of that is stable and that they're motivated. I see a lot of patients who expectedly have low mood or are depressed. The last thing they want to do is go to hand therapy 3 times a day and go through a big reconstructive surgery. They have to have available donors. You have to have something that you can transfer. We typically say this muscle has to be at an M4 level or greater, with that common knowledge that when we transfer a muscle or a nerve, we're going to lose one MRC grade. So you want it to be strong enough that you still have anti-gravity after you make that transfer and full passive range of motion of their joint. And looking at your reconstructive priorities. Now, this is different than your brachial plexus population. For a lot of patients, the most common injury level is C5, C6. So they have elbow extension, whether that's through BR or whether that's through biceps. What they may not have is elbow extension. And next on your priority is wrist extension. This is the foundation of reconstruction in SCI, I would say, is their tenodesis effect. This comes from the natural balance of your flexors and extensors. In all of us, when we extend our wrists, our fingers and our thumb naturally curl in to form kind of a rudimentary grasp and rudimentary pinch. And when we flex our wrist, our fingers naturally open. A lot of patients before reconstruction, they figure this out. They use their tenodesis to use their wrist to drive and to hold on to larger objects. But this is not truly coming from their finger flexors. This is all coming from their wrist. But if they have wrist extension, or if you can give them wrist extension, you can build on that. You can give them more. So after wrist, active pinch, which is for me, lateral pinch, the thumb to the index finger, not so much tip pinch, and then active grasp. I tell patients this is moving all 4 of your fingers together, but being able to bring those into the palm. And then finally, hand opening. Most patients with tenodesis, they can open their hand and let go of objects, so we don't often actively reconstruct this, although we have some really great nerve transfer options to do that. So 2 main reconstructive categories. You have tendon transfers, and that's if you have a horse that's not working anymore, that's tired, you can hook it up to a new horse or to a new motor. You're taking a muscle above the level of injury that they can control, that's working, and you're transferring it to give them function below the level of injury. And for a nerve transfer, same idea. I tell patients this is like rewiring the electricity in your house, taking something from above the level of injury, but a nerve, and using that to power something below. Don't have all of the time to go into the nuances of choosing tendon and nerve transfers. I'll show you a few cases, and maybe we can save that for the discussion, when to choose one versus the other. The one thing, if you're examining spinal cord injury patients, the one paper to read is, I have the reference later on, I think it's JHS, but Jongford. This is the International Classification for Hand Surgery, and this is what I would base my physical examination on for a patient with SCI. So this is looking at how many muscles below the elbow are usable, or how many muscles can you use to transfer. And these are muscles that have at least an M4 grade. So for example, a patient who is an IC1 level, they have brachioradialis. They don't have any of these. They don't have wrist extension finger, but they have BR. For a patient who is an IC2, they now have wrist extension and they have BR. So they have 2 muscles below the elbow that are potentially usable. And this is all based on tendon transfers. For the patient who is an IC grade 4, they have pronator teres, ECRB, ECRL, and BR. So they have 4 potential muscles that you can use. And if you communicate with anyone else across the world and you say, I have a patient who is tetraplegic, who has a right hand, who's an IC3, left hand IC4, they can already picture what that clinical exam is. It's a really useful way to succinctly describe a patient that you're examining. And for me, when I'm looking at a patient, my clinical exam, I start with BR, then I go down the line. Again, for your patients with an incomplete injury, whether that be inferior posterior cord, hemicord, this doesn't work as well, but I still use this framework. Even though a patient might be an IC4, I still examine the rest of the muscles just to make sure I'm not missing anything. So then that becomes, when you're trying to figure out your reconstruction, it gets back to kind of an old question, hand surgery. What do I need and what do I have and how do I bring those together? We've already talked about our priorities. And for this talk, I was thinking we could focus on the hand rather than looking at shoulder. We'll get into that a little bit. But if you think about your priorities, first you want to restore wrist extension. You can do that through tendon transfers, and these are your options here and your possible donors, or you can do that through nerve transfers. I have supinator and brachialis highlighted These are two great nerve transfer donors because they don't burn any of your tendon transfer options. I'm not going to use supinator. I'm not going to use brachialis usually to power a tendon transfer. I can use those for a nerve transfer without really worrying about, am I taking away the opportunity for something else if my nerve transfer doesn't work? Your ECRB, your BR, your pronator teres, you can use those as nerve transfer options. You have to be a little bit more careful though, because if you use those as a nerve transfer, you can't use them as a tendon transfer because you'll have already used that nerve. So then if we're thinking about reconstruction, if you have a patient who's IC1, that means they don't have any wrist extension. All they have below the elbow is brachioradialis. What you want to give them, what we said was the foundation of our reconstruction, is tenodesis. They're not able to do this on their own. So you can transfer BR to ECRB as a tendon transfer, and that will give them a hand that looks like this. They'll be able to extend their wrist. They can't move their fingers or their thumb, but they can form this rudimentary position. You can then go in and you can tighten or tenodese their FPL and their long finger flexors to make that a little bit tighter so that they can use their wrist to then power passive grasp and pinch. It's passive because it's all coming from the wrist. They're not moving their fingers. It's all driven by their tenodesis. So for your IC1 patient, you can give them tenodesis and you can tighten everything else and maybe give them a rudimentary fist. For the patients who's IC2, remember now they have ECRL, so they have wrist extension, but they also have brachioradialis as a possible donor. You can then use BR. You don't need it for wrist anymore because they have wrist naturally, so you can bring BR to FPL and give them active pinch strength. And for their grasp, you can just tighten the long finger flexor. So now you're giving them a little bit more function. You're giving them a pinch that they can use. And then for patients who now have ECRB, they have wrist extension. They have two wrist extensors. So then you can use one of the wrist extensors and then build on that. You don't need wrist extension anymore. You've got that already. You can use your BR to FPL like you did before. And now you can use your ECRL for something else. You can use that to power their FDPs for active grasp and pinch. So you're building their tenodesis. Once you have that, then you can build active grasp and active pinch on top of that and give them a hand that is more useful in terms of being under their control. So that IC2 to 3 level is where you really go from a passive reconstruction to truly giving patients an active reconstruction of. So we talked about our reconstructive priorities. We went through some of the tendon transfer options. How do you do this using nerve? For the nerve transfer for elbow extension, we'll go back to the tendon transfer for a second. You can bring biceps to triceps or you can bring posterior deltoid to triceps. It's two different options as a tendon transfer to try to give them elbow extension. For the nerve transfer, you can do the opposite of what we would do in a brachial plexus injury, and you can go axillary to triceps to try to give them extension. For wrist extension, you can use your supinator to power that. For active pinch, you can bring something into AIN. And a lot of this depends on what else are you doing for their tendon transfer? What donors do you have? The supinator is a great donor as a nerve, like I said, because you're not burning any other options. And if you make an anterior approach, you can bring that either to the PIN or to the AIN, depending on the patient and the level of injury. There have been more recent studies talking about reinnervating the ulnar FTPs to give them truly finger flexion to all of them. With their AIN, if they get good AIN function back, you can do a tenodesis of their long finger flexors and still be able to give them the ability to make a full fist. And I would say the one nerve transfer that works great in tetraplegia is your supinator to PIN for hand opening. Okay, sorry, that was a whirlwind of kind of a general overview of all the different things that you can do. I think what's hard early on is figuring out what to do when and how do I piece all of this together. We'll go through a first case on nerve transfers. This was a very young patient that I saw around 7 months. She's a C6 ASIA, so complete spinal cord injury. I really like the spin transfer. It works really well. Supinator is a great donor. And do a spin transfer on both sides for hand opening. And the beauty of combining nerve and tendon transfers, the nerve transfers for pinch is a little bit more dexterous. They have the ability to control that a little bit more finely, but the tendon transfer for pinch is a lot stronger. And they get that back earlier than the nerve transfer. So for her, we decided to do tendon transfers on the right side for grasp and pinch and nerve transfers on the other side using ECRB to AIN for pinch using nerve transfer. So combining the two. For the nerve transfers, remember back to that initial slide, we talked about how we can do these late. If it's a true upper motor neuron injury, when you go intraoperatively and you stimulate, if you get anti-gravity stimulation and that still works, that tells you it's a true upper motor neuron injury. You can do those nerve transfers late, even 12 years. So this was a case report by Dr. Fox, and there's been many others. But I tell patients before, if I see patients late going in, I'm going to check intraoperatively based on stimulation if it's okay or if it's safe to do this transfer. So for this patient, I do an anterior approach. I know Nikki has written a paper looking at the different approaches for the supinator to PIN nerve transfer. I do this so that I can do the ECRB to AIN through the same incision. And I come right down onto brachioradialis. I lift up that BR muscle, and the first nerve I'm going to see is the SSBRN. If I dissect just lateral or radial to that nerve, I'm going to find the nerve branch to ECRB. And if I follow this up proximally, then I can find the main PIN diving under the supinator muscle here. So that's lifting up the edge of that supinator muscle. You'll find your supinator muscle, yeah. On the either side of the PIN, you'll find the supinator motor branches. So there's one here in this vessel loop and one here, and they're very classically one on either side of the PIN. Then if you move more medial in that same incision, you can find the median nerve and the branch to the AIN and bring your ECRB over to that for your second nerve transfer. So intraoperatively, when you stimulate, you can isolate. This is her contralateral side when we did the spin transfer, the same side. But you can see, you can isolate the supinator motor branches, make sure that you stimulate. This is above the level of her injury. So supinator, I expect to be working. This is higher than where her C6 level injury is. What I want to make sure, though, is what I'm trying to transfer to the finger extensors and the thumb extensors, that those are working. So this is a patient at 7 months. She's still stimulating, which tells me this is an upper motor neuron injury. If she did not stimulate intraoperatively, I would still do this nerve transfer because I can get the nerve innervation to the muscle in time within that 18 months. If I saw this patient at 12 years and she stimulated, great, I'm going to do this nerve transfer. If I saw her at 12 years and she did not stimulate, that's lower motor neuron injury. I'm not going to do that nerve transfer because it's too far gone for that muscle. So your intraoperative check, regardless of what your pre-op EMG, physical exam, functional electrical stimulation shows, your intraop nerve stimulation is your last check to know if it's safe to do that nerve transfer. You want to make sure that it's stimulating or that you can get something there by that 18. So this is the nerve transfer, the spin transfer, and the ECRB to AIN. This is her at 6 months. So she's starting to reinnervate her spin transfers. This is about the time point that I would expect. The ECRB to AIN nerve transfer takes a little bit longer to kick in. So we saw some nascent units on her EMG, but she's not seeing anything active yet. So we're seeing that spin coming in. And the great part of doing the spin is that sometimes patients get enough APL function, EPL, that you don't need to maybe do a CMC arthrodesis or something later on. They get really nice hand opening. The one key point here, this is a great transfer. I've seen some patients be referred from the outside with just this transfer. If this is all you do for a patient, they will lose their tenodesis. So you need to have a plan for how you're going to give them finger flexion. These patients with their spinal cord injury level have no active flexion. It's all driven by their tenodesis. So if you give them a spin and their fingers now can extend and they do this, they're not going to be able to use their tenodesis anymore. So you need to have a plan. For her, we decided to wait for her AIN to come back. And if it didn't, we still have tendon transfer options for. You just need to have a long-term plan. Otherwise, you're going to take away their tenodesis and they're going to lose function. Even though your nerve transfer may have worked, you're really not helping them and doing them a disservice if that's the only thing that you've planned. Okay, and just double check the time. So I was hoping we can all work through this case together. And I know Joanne and Kira on the line. I've met them before, so I might call on them to help.
Please, and don't be nice.
This is a 46-year-old patient. He's a C6 AISD, so incomplete central cord. He has central cord syndrome, so incomplete spinal cord injury. And this is from an injury in 1999. Does anyone know what the hallmark is of central cord syndrome? What is the classic finding?
Can we go to a resident? Wait,
Yeah, we need
before
a
you do
resident.
Sure.
the fellows, let's have a
Who are
resident answer this.
the
Amber.
residents?
I see
Julianne,
Amber.
you wanna give a shot?
For central cord, you typically have upper extremity weakness when compared to like lower extremity, so it's more isolated. Um, and obviously like there's a great mismatch that you can kind of see when you have a central
Yeah,
cord lesion.
awesome. So they have upper extremity, their upper extremities are affected much more than their lower extremities. So this patient is able to ambulate independently. He walked in my clinic. I thought he was a hand patient looking at his hand. I thought he was a chronic ulnar or something. He has some mild bowel and bladder issues, but he doesn't need catheters. He's managing those with just medications. But let me show you his hand. So we'll focus just on his left hand. We can talk about his right too, but we'll focus on the left. And maybe we can have one of the residents just describe what you see. Oh, I gave it
So
away.
no. Amber or Gary, if either of you are listening, can you describe what you're seeing?
This is his tenodesis, and I'll play this again here. You sort of see his muscle grade there, but what are you seeing on his left hand first? Sorry, I don't know why my
Um, so he's unable to like make a full fist. It looks like he also lost his ability to like grasp and clench using that left hand.
so he looks like he's flexing his fingers there. How do you think he's doing that?
It looks like he's doing it like through his MCPs.
Okay, and what are you noticing about his wrist when he's trying? So he can't do it against
Yeah,
gravity, but what are you noticing with his wrist when he's doing that?
that when he does it, his wrist goes into extension.
So that's his tenodesis. He doesn't have any true finger flexion, but he has tenodesis, and that's what he's sort of able to cheat with that. So if you're looking at his hand very quickly, you might say, oh, maybe he has some FDS FGP, but that's purely driven by his tenodesis effect. Maybe one of the fellows, what do you see on his right hand? What does that resemble? The way that he's flexing his fingers in.
Show it again one more time, Dr. Will. He's kind of, when he's going down, he's kind of curling and pulling it in. It's not like a complete, he's kind of like walking himself in, I think.
Right. So we see that a lot in patients with chronic ulnar nerve palsy, where because they don't have intrinsics, when we flex and we grab, we typically flex our MPs first before we activate our long finger flexors to be able to grab around an object. Patients with ulnar nerve palsy and in him, because of his spinal cord injury, it's almost like those party streamers where your fingers curl up like this. So when they're trying to grab something, they actually push the object away because of the way that their hand's functioning. So I already showed you guys, but this is his strength sort of grading. How would you guys classify them? If you were telling Dr. Zelinsky or Dr. Wagner or Dr. Sue about this patient you just saw, you say he's an IC what? We'll start with his left hand. Anyone want to take any guesses?
So he's got weak wrist extension. So, and that's how he's giving himself the tenodesis effect. So I would say he's a 2.
His wrist extension is actually very strong. So he's
Oh, 3.
powering his tenodesis through his wrist extension, but his wrist extension is really strong. Typically, when a patient's in MRC5 for their wrist, we usually say that they probably have both wrist extensors. Your pronator is also the next muscle down after the wrist extensors are innervated. So typically, if patients have ability to pronate, they probably have 2 wrist extensors as well. And remember, for your IC class, the muscles need to be at least an M4 strength for them to qualify. So, Kara, I see you're unmuted. Do you have a guess?
No, no.
Okay.
Sorry.
No, that's okay.
I'm
So he's
always
probably an
unmuted.
IC4. So he's got brachioradialis, he's got 2 wrist extensor, and he's a pronator, which is a 4. So he's an IC4 classification. He does have some function here, but they're all too weak for us to use as a potential donor. Okay, so I know we've skipped to the next slide, but he has strong elbow extension, so we don't need to worry about that. How are we going to give him grasp, pinch, and hand opening? Any thoughts? I know the first part was a whirlwind and super fast, but
He's got yeah, he's
So
got
he's
good
got,
VR.
sorry, go ahead, Kier.
No, you're
But
good.
he has BR, like Kier said. So I think you just mentioned BR to FPL.
Okay.
Um, could give him a lateral pitch.
And then what about for grasp? What can we do there?
You have ECRL
Um,
then. Do it to FTP.
Yeah,
Yep.
or BR. Or yeah, ECRL, sorry.
Okay. And for hand opening, he has one in his EPL, he has two for the EDCs. Do you think you would add a spin transfer for him? His injury was 26 years ago, but we know that it might be a possibility. So if you could stimulate intraoperatively and you got great finger extension stimulating that PIN, would you do the spin transfer?
Based on your results, yes. Looks like it works pretty well.
Okay. Anyone think any differently? So it's a little bit of a gray zone. In my hands, I would probably say no. Not to say that, I think this is a discussion you have with the patient, but my reasoning is he has some EDC extension and some EPL function. That spin transfer is an end-to-end nerve transfer. So by doing the nerve transfer, by cutting that PIN to put in my supinator, I'm going to take all of this away. So potentially, it's a great nerve transfer. It works well. Potentially, I could reinnervate this and give him maybe M4 and M5, but there's a chance that I might not. And there's a chance I might lose that. And also, it takes at least 6 months to reinnervate. So he's going to have 6 months where he doesn't have any finger extension. So in my current algorithm and talking to the patient, it wasn't quite worth the risk. He had enough extension that he was happy with it. He can open his hand with tenodesis. So we decided to leave that out. Although the spin transfer is a reliable transfer, and I know some groups in an M1, M2 patients may talk about adding that nerve transfer. Okay, so this was the plan for the patient in this order. I'll go through each of these steps, but the wide awake ECRL tenotomy, I cut the ECRL and I want to make sure that they still have really strong wrist extension through ECRB before I move on to the nerve transfer. So I start the first part of the surgery with the patient wide awake or under very light sedation, and I wake them up and make sure their wrist is strong after I've cut ECRL. I then fuse the thumb CMC, that brings their thumb out of the plane of the hand. That's set up for my tendon transfer. Do a house intrinsic tenodesis to help with that MP joint flexion. You can also do a Zancoli lasso. And then, like you guys suggested, the BR to FPL and ECRL to FTB tendon transfer for active grasp and pinch. And the EPL loop knot is most patients, sort of like when you see ulnar nerve palsy, when they have a positive Frohman sign, their thumb IP joint tends to flex when they're pinching. So to help with that, I imbricate the EPL to give them a little bit more extension so that they're pinching more through the pad of their thumb. Okay, so let's go through each of those steps. These are the various incisions. This is for your intrinsic tenodesis, these incisions here. This is for the ECRL, and this incision here is for their tendon transfer. And they have a higher one up as well for the BR to FPL tendon transfer, which I'll show you in a second. So the first part through this incision, this is with the patient just under local anesthetic. I find the ECRL and ECRB tendon, and I'm cutting the ECRL, and then I'm making sure that they can still extend their wrist. And they have to have M5 anti-gravity wrist for me to move on. And if they do, great, put them under general anesthetic, continue with the rest of the case. If they don't, then it's not safe to take the ECRL because you're going to weaken their tenodesis. So then I will put ECRL onto ECRB and suture those two together to help to centralize the wrist. A lot of these patients tend to radially deviate when they extend because they don't have any ECU. So you're still not, you're not, I guess, burning anything. You're helping the wrist, but you know that it's not safe to transfer. And I've been doing this for most patients just to make sure, because the last thing I want to do, we know how important tenodesis is. The last thing I want to do is take that away. Then thumb CMC fusion to position them. I prefer 2 staples. This K-wire is just there to help hold a temporary provisional reduction. I usually remove it. I don't K-wire them unless there's some concerns with the bone stock. I position them in 30 degrees of extension, 30 degrees of palmar abduction, so their thumb is out of the palm of the hand. When I'm landmarking, I want the thumb, when they pinch, the thumbnail plate to be parallel to their index finger. and to land right on that the middle phalanx of the index finger. So I'm using that as kind of a guide when I'm trying to position my CMC fusion. For the house intrinsic tenodesis, has anyone seen this or done something similar for an ulnar claw correction? No. Joanne?
We've seen Zancoli's, but I haven't seen a house yet.
It's a passive positioner, and it helps to recreate the lumbricals by flexing the MP joint. So I do this using a plantaris allograft, and you're bringing the tendon allograft from the radial side of the index finger around the metacarpal and then into the radial side of the long finger. So like this diagram is showing, and you're doing that similarly for the ring and the small. This is from a different patient who had a dynamic transfer, but the surgical steps or the technique is similar. I use a Carroll tendon elevator and I pass it. The most important part is you have to go deep to the transverse metacarpal ligament. You're going deep, coming all the way along the radial side of the metacarpal and bringing this tendon allograft back through here. And in this patient, this is a different incision because I put it into ECRB, but for a spinal cord injury patient, you would then take this Carroll elevator, put it along the radial side of the long finger through that lumbrical canal and bring that same allograft back this way to create a loop. You do that on both sides. One of the key technical points, and similarly, if you're doing this for an ulnar claw correction, is you want to bring that allograft not into the extensor tendon, but into the lateral phalanx. If you're bringing it into the extensor tendon, you're recreating both MP flexion and IP joint extension, and that's going to fight your tendon transfer for their FDP. So you want to be careful that you're seeing that anatomy clearly when you're just putting it into the lateral bands there. The BR to FBL tendon transfer, I don't have photos from this particular patient, but from an anatomy lab dissection. These are the two incisions I would use for that if isolated. In that distal dissection, this is similar to if you were releasing BR for a distal radius fracture, you're going to find BR right along the distal radius. Make sure you're seeing those first extensor compartment tendons before you're tracing BR. And then in this proximal incision, this is essentially if you're putting on a bridge plate, this is a similar dissection where you're seeing BR, ECRL, and ECRB. On the other side of BR, though, is your radial neurovascular bundle. So you want to be careful when you're dissecting BR, especially proximally, that you're protecting that on the deep surface. The key point to doing this tendon transfer is you're releasing BR very proximally. You have to release all of these fascial connections to get the excursion that you need. Oftentimes, I'm working in between the incision in the forearm and their supinator to PIN nerve transfer incision to be able to release BR fully on both ways. And you really want, the textbooks say 2 centimeters. I work really hard to try to get as much as I can, 3 to 4 centimeters. That's going to make that tendon transfer work. And then for most of these tendon transfers, I'm doing an end to side tendon transfer. The only case where I won't is if patients have a lot of spasticity in their hand and they're really clenched down, I want to lengthen them. Then I'll cut the FPL proximally, let that slide and do an end-to-end tendon transfer and lengthen them at the same time. But this is often an end to side. For your ECRL to FDP tendon transfer, different patient obviously, also doing an end to side tendon transfer. This is that ECRL through that small incision where we already cut it. I'm bringing it around the radial side of the wrist and bringing it end to side into those FDPs. These two sutures here are the yoke stitch. So I'm bringing all of the FDPs together to maintain that cascade so that when I'm putting in my tendon transfer, I'm not distorting it. So I put in the yoke sutures first, and then I'm bringing that tendon transfer in. Okay, so back to our patient. This is the intraoperative tensioning. So I'm using his tenodesis passively to make sure that he's able to open his hand. His MPs are flexed because of that house tenodesis now. And I'm making sure that those fingers are curling into the palm with a nice cascade. Your breaker radialis, remember, it originates above the elbow. So when you extend their elbow, that's when that tendon transfer is going to be the strongest. So this is still something I struggle with, and I spend a lot of time worrying in the OR, is this too tight? Is this too loose? And now I found using a pen, I want them to be strong. In full extension, I want them to be able to hold on to their pen strong enough that I think they could hold on to it to write. And I pull it to make sure that it's not too tight. But when they're flexed all the way, I want to make sure they're not so loose that they're dropping the pen. So that's kind of how I'm trying to dial in that tension by using that. And This is that same patient. He's 6 weeks post-op. He's still working on range of motion. He's still using his wrist to augment it a little bit, but oh gosh, sorry. I'll go back to that one. But he's now starting to get some long finger flexion back and working on therapy. This next slide is a different patient who's a little bit further along. So what can these tendon transfers give patients? This patient's now 4 months, very similar procedures, but he's also had the spin transfer. He was a complete spinal cord injury. He's out of state. That's why this is a video of our virtual visit, and I don't have a video of his hand. And he's wearing a lumbrical bar still because he uses a manual wheelchair, and I'm a little bit worried when he's pushing with his hand that he's going to stretch out the house tenodesis. So I still have him wearing that when he's in his wheelchair driving. He's got really nice full grasp, and he's got a really nice pinch. And this is him at hand therapy, showing the ability to actually use clips. For him, the biggest thing the most important thing to him was that he could wake up, he could grab a coffee pot, and he could pour himself and his wife a cup of coffee in the morning, which he wasn't able to do. So in the literature, what can we expect? This was a study from Joanna Wandell from Sweden. So overall, looking at all of their patients, all IC grades and injury levels, you can expect about 2 kilograms of pinch strength and about 5 kilograms of grip strength. They did find that patients with an IC4 or higher had higher grasp ability because we can do an active transfer rather than passive, but there wasn't any difference that they saw in that pinch strength that they were able to get for patients. Another long-term study that was published recently, this is looking at patients who had over 20 years, patient follow-up for reconstruction. This was 34 patients, the mean follow-up was 14 years, and 92% of patients stated that they benefited from surgery. 11 patients were able to drive, and 10 patients said that this was possible because of their surgery, that they were able to be more independent. So we all know this quote from Sterling Bonnell. I think there's no other patient population which this applies more for. If you think about patients with amputations, with peripheral nerve injuries, brachial plexus injuries, which are devastating, a lot of those patients still have a contralateral hand that is fairly normally functioning. The best reconstruction that you give them is likely still going to be a helper hand that they'll still prefer to use their contralateral side. For patients with spinal cord injuries, those with complete injuries, all 4 of their extremities are affected. They use their hands for their wheelchair to get around. They use their hand to reach out, to use a phone, to interact with the world, to use their tablet, to eat and drink. Everything is reliant on their hands. We saw in the beginning how important patients are. So really in these patients, anything that you can give them, any little thing that you can give them, they will use. And it's been a really rewarding part of my practice so far. This is a patient who was one of my first patients. We did his first side. His spin transfer still hasn't kicked in here yet, but able to pick up a pen, and he's showing that it's pretty strong, that he's able to hold on to it. And I think one of the really encouraging things early on in my practice that has really fueled the drive to want to help patients with spinal cord injury is seeing him being able to pick up a pen and sign consent for his other side. I think it shows just what a big difference this has made, that he's willing to undergo the therapy, the surgery, the travels, and to be able to do that again. So that was a really great moment to see early in practice as a great encouragement factor. So if anyone is interested, these patients will be so thankful. It's really beautiful anatomy. You get to see the nerves, the tendons in the forearm. It's great teaching cases for fellows, for residents, and it really means a lot to these patients. So thank you so much for your time. I'm happy to take any questions. Thank you.
Amazing. That was awesome. Really, really impressive and really cool stuff. Very, very, very exciting stuff that you guys have kind of really innovative. And I'll be honest, that stuff was not going on when I was there. So really cool that's happening. I'll open up. Anybody have any questions?
Yeah, I have a question, Kate. So awesome talk, very interesting to see for sure. When you do your house transfers, are you tying the graft in proximally at all to anything? Like, do you stitch it in, or you literally just put the allograft go above and around underneath the extensor tendon and then back in the lumbrical canal, literally on both sides? And then does it just scar in? Like, how does it not slide whenever, it's just the soft tissues?
It's just the soft tissues, and it's just around the metacarpal neck. So it's kind of the head of the metacarpal that's preventing it from sliding distally. So I set in the 2 allografts, you suture in the first side, and it's your second side that you're tensioning. That's what's
No, that makes
deciding.
so essentially it's sitting behind the sagittal bands, essentially.
Correct. Yes.
Yeah, that makes a lot. Okay, so it's actually a lot more distal because the one photo you have is when you went proximal for like a brain transfer almost type of thing.
Correct. Yes.
Yeah,
Yes.
so that
It's a
makes a
lot
lot
more
of sense
distal.
then.
Yeah.
And
It's
then
kind
your
of right here.
tensioning, you said when you tension it, your tensioning is based off of anything specific or
Uh, I struggle with the house a little bit because I worry about making them too tight and then they can't open their hand and have the spin transfer work. For me, I set their wrist in about 30 degrees of extension. I'm trying to tension them just about 90, but I'm making sure that passively I can get them a little bit more beyond that. I don't have a good science sort of paper say, 30 degrees and then bringing them to 90 to 100. For the dynamic transfers, when you're bringing it to the wrist extensors, you don't even have tenodesis because if you put it into ECRB, when you extend the wrist, it gets even tighter. But for these patients, for just the house tenodesis, I still check with their wrist that they're not fully like this all the time, that they have a little bit of opening.
yeah, really cool. Great pictures, great videos. Fantastic job. That was awesome.
I have a question, Kitty.
Yeah.
Dr. Awesome talk, great pictures, loved it, loved the cases. For that last guy, was curious that I kind of thought that you were gonna walk us through some awesome nerve transfers that you did for him. So why did you choose to do tendon transfers instead of,
Yeah.
the classic nerve transfer combination for that one?
Yeah. For the patient that had the injury 26 years ago, I talked to him about nerve transfers. He just sought treatment late because he didn't know that hand reconstruction was available. The nerve transfers for pinch, the ECRB to AIN takes about a year, year and a half, and the brachialis to AN takes, most papers say, about a year and a half to 2 years to reinnervate.
Yeah.
He's a farmer. I said, you can get more dexterous pinch, but the tendon transfers by 6 weeks to 8 weeks, they're using it. They're doing really well, so they're really strong. So I'm still working out my own sort of algorithm of when to offer what. It's really hard though to say I'm going to make you wait 2 years to get pinch back if I could give it to you reliably using a tendon transfer. So the young girl, when we did nerve transfers on one side and we're waiting to do tendon transfers on the other, I think that's a good balance. Or for the patient who's not able to go to hand therapy, if they're really rural or for whatever reason, other health reasons, they can't go to hand therapy early. Those ones I'm actually more favoring the nerve transfers. The tendon transfers, if you don't get them into therapy, they scar down and they're not going to work or glide. For the nerve transfers, yes, they can work on prehab, on activating the donors, but that therapy, until we get reinnervation, is a little bit less important. So that's been sort of my decision-making factor. But I did talk to him about nerve transfers because I said, if we can go in intraoperatively, stimulate. If you don't stimulate and I can't do the nerve transfers, we can do the tendon transfers as we were planning at that same surgery and make that decision during surgery. But when I talked to him about the time of waiting for nerve reinnervation, he decided he wanted the tendon transfers instead.
Yeah, no, I mean, I think that's a great point. I also offer that distinction, and I have many patients who choose tendon transfer over any fancy nerve surgery, even when it's possible for an acute nerve injury. When you tell them it's going to work at 6 weeks versus you have to wait a year, they are oftentimes easily swayed. My experience with the supinator to AIN transfer is much more rapid, so I don't know. I mean, just something to think about in your practice.
Yes.
It actually works extremely well, and it's much quicker because you're much closer to the target. And then it's so funny that you say that about the nerve patients or nerve surgery and the lack of therapy. That's like the majority of my patients can't get to therapy, unfortunately. And I also have noticed that. It's like completely changed my practice because you could just do a nerve surgery and it works. They honestly oftentimes, unless it's like some weird little like hand intrinsic one, they don't really need a ton of therapy. It just sort of starts kicking in, especially if you're doing a synergistic nerve transfer. So I also find that to be a decision point in my practice. So
and you don't need to really immobilize them as much, or I worry a little bit less. I just say don't lock out your elbow. So for the patients who I may not trust to stay in their post-op splint, I maybe sway them one way or the other. The great part is you can say, well, I'll do nerve transfers on your contralateral side. You'll have a soft dressing. You can still use your hand while we wait. And we can do nerve tendon transfers on the other and kind of do both at the same time.
Totally.
It's been a good mix of things. And I'm still learning as well in terms of what the right algorithm is.
Yeah, it's going to depend on your patients. I also think it was smart not to do supinator to PIN for that one because you can always do it later, right? If you wanted to,
Yeah.
if for some reason your tendon transfer overpowered what he has, you can always go back and try to do a spin transfer on him.
Yeah.
No, Drew, that was, oh, sorry. Go ahead, Julian.
No, you're good, Joanne. Go for it.
That was a fantastic talk. I am wondering, how do you manage spastic muscles? Like if that's all your only option, can you use them? Are you like using Botox at all to try to like weaken them, or are you doing like partial tenotomies? Like how do you manage those?
Yeah, that's a really great question. I think really tough. It's hard on your exam to know if someone is weak because they're truly weak, or if they're weak because the antagonist muscle is spastic. And that's hard in spasticity, and that's hard in spinal cord injury. With complete injuries, they have less spasticity. Those incomplete patients who are already the more difficult exam to start off with that are challenging. So for those patients, I will do Botox first, and I see them about a month and a half or 2 months after the Botox, so I can re-examine them and see, are they actually weak on those muscles? Do I need to reconstruct them, or was it their spasticity? For patients who have debilitating spasticity, I typically will treat them and do spasticity surgery first, whether that's or lengthenings or hypersectorectomies, and then do their SCI reconstruction later on. Unless it's, for example, someone who has isolated long finger flexor or thumb spasticity, I can treat those by doing my tendon transfers end to end because I will lengthen their FTPs, I will lengthen their FPLs by doing that tendon transfer anyways. So that's probably the one case where I'll combine them. I think for me, there's too many moving parts and target early on for me to decide this is the right surgery to do everything all together. So I tend to try to treat their spasticity, definitely use Botox or local blocks, treat their spasticity first, and then do tendon transfers or procedures for their spinal cord injury later on. But it is an area that I don't think there's a set, algorithm right now of what the best thing is to do.
Thank you.
Joanne and I have similar names and I think similar thought processes because I was going to ask about spasticity also. To follow that up, after you've done the transfer, if you're going to do a transfer in a patient, do you continue to require, if the patient's been doing well with Botox, do you continue to treat that transferred muscle tendon combo with Botox, or how does that go?
Um, the the two that I can think of that I did end to end tendon transfers for spasticity haven't needed it, and typically they shouldn't if you've lengthened those tendons. Although, potentially if I follow them long enough, if their muscles are still spastic, perhaps that could be the case. But haven't had to so far. And if we're just outside of the SCI world, if we're just talking about pure spasticity, most of your surgical procedures for spasticity, they should not require Botox in those same muscles that you've treated after that surgery. They may require Botox in other muscles now that may be overpowering or their balance is a little bit shifted. But in the muscles that you've treated, hopefully they shouldn't require Botox.
Gotcha. And in that patient that you mentioned earlier that had the nerve transfer and the tendon transfers just on contralateral sides, did she shed any light onto which one she ended up preferring or have any reasoning for one versus the other than the traditional, one's quicker, one's more straight?
That's a great question. I haven't done her tendon transfers yet, and her nerve transfer hasn't reinnervated. That's why I don't have her complete set of follow-up videos. Talking to other patients that have had one on one and one on the other, the tendon transfer they can use earlier on and they find it stronger, but they'll pick up things like chips are really hard because it requires enough strength to hold on to it, but not so much that you're going to crush it. So the nerve transfer works really well for smaller, fine objects where they have to dial in their pinch a little bit more. So I don't think they prefer one versus the other. They will say that they use each hand for different things. They'll use their tendon transfer side to grab onto a water bottle or a cup or a coffee mug, for example, and they'll use their other side to pick up grapes is a common one, Cheerios and chips and things like that. They'll use their nerve transfer side for that because they find it a little bit more, I think you can dial in the control a little bit better.
Say any other questions? Katie, I have a couple questions for you. One, the um, the CMC fusion. So you use the staples. Have you had success with staples? I have to admit, I early on tried a couple staples, not on CMCs, but on other things, and found it a bit fuzzy and didn't quite have the success. But that being said, I guess I'm potentially not using it right. And then two, um, the when you're positioning it, one of the difficult things I find about CMC fusions, and maybe it's because I'm using screws, but it's such the SCD joint is such a mobile joint. I find it difficult to truly get in the position I want, or at least I fuse in that position, and by the time it heals, it's like in a slightly different position than I was hoping for. How do you maximize that?
Um, Interoperative for positioning, I'm really aiming to land the thumbnail plate to the index finger. And I think probably the CMC fusion as a positioner in SCI, those patients have lower demand, I would expect, than CMC fusions for arthritis or the heavy manual labor per se. So that's what I've been using to position it. I'd love to hear how you're doing it as well. For the staples for both CMC arthritis and for SCI, I've liked using them. The one thing I don't do a cup and cone. I create an osteotomy, and sometimes that can get a little bit futzy because if you have to extend the metacarpal, then my screws aren't sitting flush, and it's an angle, and then I have to make a trough and stuff. So that's I think early on in practice that was a hard learning point to not create such a big angle in the metacarpal. I used to always think I have more room in the metacarpal. I can futz more there, but I think for me, I've now tried to dial in my fusion more on the trapezium side of things. But I think being careful about that, the staples have worked well. I haven't had any non-unions, knock on wood. But again, I don't think these patients are as hard on their thumbs after, and I'm protecting them a lot because of therapy, because of their splints, compared to doing maybe the CMC fusion for another indication. But what are you using for positioning? And I think for thumb CMC fusion, I'm more wanting them to have more that tip pinch and maybe not landing right at the phalanx.
What's
Yeah,
crazy
no,
is
that
Marco's the one who actually said I guess he shifted towards like staples almost exclusively, he was telling
Yeah.
us.
Yeah, Marco and Peter Ree here are using staples. That's where I sort of learned, fusing thumb CMCs from both of them. So that's, it's worked well so far, being careful of those few technical.
And you said you're just preparing. I'm sorry, now let Wax talk. But it sounds like you just prepare it with a small little sagittal saw, just making a direct cut on both the trapezial side and on the metacarpal side.
Yes, yeah. I'm making the cut on the metacarpal side first, almost perpendicular to the metacarpal, and then I'm positioning them and trying to dial in that angle on the trapezial side. That's worked a little bit better than trying to do it vice versa, because then the screws I find just aren't sitting as flush as I would like them to be. But I, love to hear what you're doing. I think it's always the futzy part, one of the futzy parts, the CMC fusion, and then the tendon transfer tensioning in these surgeries.
Cool. That's really cool. Any other questions?
No, Wags, I think she was asking what you're using on the CMCs.
Oh, I use screws. I use Herbert screws or cross screws. It's a little bit different. These are usually like young, really young. Usually some aspect of post-traumatic. So I think it's a little bit different. But I do find it klutzy getting the position right. And then when I put it in a certain position, I have to feel like by the time they're actually healing and all that stuff, it's not. I just find it doesn't always translate to what I thought I put them in. So I find it a bit klutzy. I guess I've done one or two in the Plexus setting before Nikki got here. But I have to admit that those patients were not super happy with it. So I don't know. Anyways, but neither here nor there. Nobody wants to hear me ramble on about CMC fusions. Yeah, at some point, Kitty, we should have you come and talk about shoulder noble too. That would be fascinating as well. The cool thing is like that's really innovative stuff that you're doing. Like I said, when I was at Mayo, nobody was doing this stuff. Maybe Steve was a little bit, but I don't know. I never really saw it. Alan Pavlovich out here does some of the stuff, but like truthfully, he's in a different group, and although he's like awesome, we really don't get exposed that much. I think the fellows do, but as a faculty, we really don't. And it's a credit to you, what you all are doing up there, really pushing the envelope and this stuff. So it's really, really cool stuff and very exciting very exciting in an area that's quite challenging, I think. So,
Thank you so much. That means a lot, especially from you. So thank you.
oh, it's cool. Anybody else have anything else, or should we cut off?
Nope, just kidding. Just be prepared when we invite you back next year to put you in the rotation of lectures.
Yeah, but then you have to talk about Shoal Novo, because then I'll have lots of comments.
Oh no, I'll politely decline that one.
But actually, no, speaking of which, actually, one of the times once we figure out our school of medicine issues and all the other stuff that's going on, once things stabilize, we'll probably have you come down and maybe show us some of the tendon transfers in person.
Oh my gosh. No, I would love to learn from you guys as well. I'm still working out, how to tension things. And I feel the Dr. Rizzo in me when I'm like, is this too tight? Is it not tight enough? And I'm moving the arm up and down. So it's
That's
still
awesome.
definitely work in progress, but thank you.
Yeah, no, that would be fun. Zelinsky is like every time I talk to Zelinsky, she has some new weird nerve transfer, and you guys always name it some like random name that like is like sounds really cool. I'm just like,
None of it
first
is
off,
new, Wagner. You just didn't know about it.
first off, neurosurgeons like
Hey,
are
I gotta
obsessed
tell
with
you, it
it.
works. I saw one of Nikki's patients, one of
I
our mutual
know, I
patients
know
back
that like
today, and they're
hand
working.
the hand one or the
What did you
thumb
do,
one. I can't
Nikki?
remember what
What
you called it,
transfer?
but
Oh, I just did like the Bertelli ADQ opponents.
Okay.
yeah, but it didn't
Okay.
have a name. Don't you have a name for it?
I call it Bertelli or
Yes,
Bertelli.
Bertelli.
I swear, I feel like there's all these weird names for nerve
No,
transfers.
she did cable grafting and a Bertelli transfer, and all working.
Yeah, I've seen. I
That's
know.
awesome.
We have a mutual patient where that transfer worked. She also has some cool radial transfer or nerve transfers that like
Yeah.
just kind of prove the point of working a little bit better than some of the ten transfers.
Yeah, I know.
True.
It
So
just
it's
takes,
cool stuff. Like
yeah,
maybe it
takes a
was.
bit of patience, but it
I'll take a
works.
lot of patience for sure.
Yeah, I find that if they go to jail for like 3 years and then come back to clinic, that's the best way. Because then you don't have to suffer through it not working for
Yeah.
like a year and a half. Then they just come back and they're like, look, everything works.
It's magic.
Great. Yeah. That'll be the indication. Patients who are incarcerated get nerve transfers.
Totally.
Yeah.
Anyways, all right. Well, thank you very much for joining us. This is
Yeah.
awesome.
Thank you so much. Thanks, everyone. Bye.
Thank
Bye.
you.
Thank you.